Dear viewers, welcome you all to our show, Orthopaedic Solution Academy. Hope you all are well during this pandemic time by wearing mask and keeping distance with each other. Dear viewers, today our topic is the correction of deformity by Ilizarov Part 2. We all know that we can only correct the deformity by Ilizarov. So the magical Ilizarov works in everywhere. And we have our learned academic expert along with the magnificent speaker with us. Today our speaker is Professor Mofakhkharul Bari, sir, the president of ASAMi of Bangladesh and the honored visiting professor of Kurgan. Sir, welcome to our show.
Thank you so much, Tanvir.
Dear viewers, we have two learned academic experts with us, both of them from India. One of them is the very popular Professor Harshad, sir, from Ramaya Hospital, Bangalore, the immediate past president of ASAMi India. Sir, welcome to our show, Orthopaedic Solution Academy.
Thank you, sir.
Thank you, sir. And the another one is the very enthusiastic Dr. Shamsul Hoda, sir, from Patna, India. I would like to request Dr. Shamsul Hoda, sir, to join with us. Welcome, sir. Welcome to our show.
Thank you, Dr. Tanvir. Good evening.
Dear viewers, we all know that the deformity is a very complicated thing, and it's a very good challenge for all orthopedicians. How we can overcome this deformity by using the magical Ilizarov. Our professor, our honorable speaker, Professor Mofakhkharul Bari, sir, will discuss it today with us. And now I would like to request Professor Mofakhkharul Bari, sir, to discuss the topic correction of deformity by Ilizarov. Sir, would you please share your screen with us? Professor Mofakhkharul Bari, sir, please.
Okay. Now you can see?
Yes, sir. We can see you clearly and hear you loudly, sir.
Okay, you can see me also, eh?
Yes, sir.
But why I'm not seeing your picture? Okay.
So we can see
okay,
your
dear
screen.
Friends.
Yeah.
Okay, dear friends. Especially my very good friend, Professor Harshad Shah from Bangalore, and Dr. Tanvir, and at the same time, Shamsul from Patna. And Professor Novikov from Kurgan, he was supposed to join, but he told me that he's not getting any link. That's why it is a problem for him to join with us. So without any delay, I would like to talk on my today's topic, that is the deformity correction. And in my last lecture, part 1, I talked about the sum of the deformities, basic thing and everything. And if you look at this history of the management of the limb deformities that I told you in the last lecture, in the pre-Ilizarov era, the only available techniques for the correction of the deformity were using only acute correction. There was no satisfactory treatment for severe limb deformities. And they have done nothing at the time, and only the prosthetic fittings and the amputation. Then in the early 50s, Professor Gabriel Abramovich Ilizarov popularized the principles of gradual destruction osteogenesis. The very important is the law of tension stress. The slow and steady traction on a living tissue gives stress, which is metabolically activated and which stimulates histoneogenesis, angiogenesis, neurogenesis, myogenesis, in a nutshell, all genesis. This is the picture where I have worked in different places. In Kiev, that is my institute where I did MS from that. This is in Tashkent, Uzbekistan. I did my PhD, and this is the Kurgan. My friend Harshad was there 2 times. And this is the orthopedic Mecca, orthopedic capital. And this is our new institute, National Orthopedics and Trauma, 1,000-bedded hospital in Dhaka. This is my present place. This is the biggest diabetic hospital. And this is another one, is a diabetic branch of the diabetic hospital. I'm working to these places. My center, my Ilizarov, and these are the, I have stopped all the videos because the internet is disturbing. That's why you can see here from the top 5 and the top 6, all the deformities, varieties of deformities. So understanding regarding the deformity correction, before embarking any kind of deformity correction, please remember Is there is a deformity or is the bone is deformed? And you should have to know the sources of deformity. It is congenital or acquired. And at the same time, level of the deformity, plane of the deformity, magnitude of the deformity, and where to do the osteotomy. And what type of osteotomy you are going for correction acutely or gradually, and which kind of fixation you are using. Since we are the Ilizarov surgeon, we love to do all the deformities correction with Ilizarov. Of course, you have other options also. You can do that, and never operate on the wrong bone. So deformity analysis and correction. Think about if you're okay, I am okay. That means there is no problem in your bones. You are in normal alignment. If I am okay, you are bent, that means how to measure and define deformity. And the intelligent gains is deformity options for correction. That means you come lie on my couch that I'll go for treatment for your deformities. And rate of deformity correction, this is my continuation second lecture. That's why you should have to understand the previous one and you should have to think the previous one. Then this is the continuation. That's why I'm going to talk on these, the defined structure at risk. You can see the three pictures here. Concavity of the deformity, which bone is affected, and you should know the soft tissue problem. Not more than 1 millimeter per day, tailored to a specific patient and based on post-operative assessment. Now, let us see some cases. This is multi-apical deformities. Look at this girl left side, 19 years old, problems in whole, right side and left side. See the angles that I have drawn. You can see the femur near the neck shaft angle. See the near the knees, and at the same time, this is right side and left side. So before going for correction of the any deformities, you should have to think yourself and measure the angles. And then see, I have corrected all these deformities only with multiple KOS. Look at this here, dear friend. This is the C here with hinges, and this is the medial wedge, opening wedge correction of the deformity. And after doing the correction, you can go for lengthening. This is the tibia around the knee joint with multiple smooth olive wires, and olive wires. These are the gradual sequential correction. Now you can see right side. If you compare this one, look at the varus knee, look at the deformity at the top, and after correcting the deformity of the upper part, these are the hinges, and this is the left side. Now if you see externally, you can see the alignment is almost okay. So this is the before, and this is after 1 year. And unfortunately, I could not show you the all the videos because Tanvir requested me not to put most of the videos. That's why I'm not showing that one. Look at this 14 years old girl, deformed right forearm due to osteomyelitis. Dear friend, this is very difficult. Look at this bowing of the whole ulna, resorption, dissociation of distal radioulnar joint, and she's running 14 years. And just to compare right side to the left side, how you'll correct this one. There are a lot of options, but whenever you Ilizarov in your hand, you can do something, and you should have to think yourself. You correct the deformity. Ulnar osteotomy I have done here, and gradual destruction I have done here. Then I've opened up a little bit, denuded this one, and fixed this with that one. Now you can see the construction of the only with the wire, no shunt pins here. And this is before, and this is after. And we have a very good video with this. And now this case, serpentine deformities. Look at this, very difficult case. 9 years old boy post-osteomyelitic aseptic deformity, what I have done, what you'll do, see here, serpentine, so bad deformities. Only Ilizarov give you
Yeah, dear viewers, I think there is some network problems. So it just hang up there, and we'll just wait for a few seconds to continue this type of program. We're facing some sort of network problems as because of it is happening all over the nation. Uh, and we have Harshad sir with us, Professor Harshad sir, and it's a great honor for us. And sir, I think Professor Bari sir is joining with us also. It's take, sir, would you please say something regarding the correction of deformity by
Yes, yes.
Ilizarov during this time?
Correction of deformities by Ilizarov is appearing very complex, but once you understand the basics of deformity correction, then one by one everything falls into place. The jigsaw puzzle is solved very easily if you know where to do what surgery and what result you can expect. Because with Ilizarov rings, there is an advantage of correcting it very slowly by distracting between the two rings so that you can correct the deformity. That is how it is, and
Okay,
gain length also.
also. Yes.
Yes.
So
okay.
now you can
Uh,
see after 2 years
yes, sir.
follow-up. So can you see this
Yes,
one
sir.
from here to here,
Yes, sir.
here?
Yes.
Now see very good, fantastic. Look at this. Of course, you can go for deportation initially. You can do that. But since we have a Ilizarov in our hand, and this is another one, trifocal bone transport by Ilizarov technique for a large post-traumatic tibial bone defects, a single center Bari Ilizarov experience, 46 cases. Now see this one, dear friend. This girl is from Myanmar. She came to my place, post-infective deformed right knee with the depressed medial tibial plateau. If you look at these, you'll not be able to understand what kind of deformity here. Three pictures. See, this is standing, this is sitting in 90-degree, and this is in just in the cord a straight way. Now you see this one, and this one. Before going for any deformity corrections, you should have to analyze the area of the deformity. Look at this, what I have done. This is C, tibial plateau is almost, this is the sloping. It must go like this. So this is the deformity you can see here. What I have done, look at this. This is the femur top, femur opening wedge from lateral side. And next you can see here, this is, I have done lengthening from the medial wedge, just elevation of this medial side. And this is corrected from the lateral side. So deformity was in the femur and in the upper tibia, lower femur and the upper tibia. So from this situation, from back side, this is the from the front view after correction. This is the back view. You can see how much deformity we have corrected. So this is follow-up after 2 years. From this situation to that situation, look at these here. A little bit, but range of movement is also good. See here, correction. And this is the elevation of the tibial plateau from the medial side. Now this is the case you can see, dear friend, fibrous dysplasia with shepherd crook deformity of a 14 years old boy. He was treated elsewhere with DHS. You can see here, bone quality is not good. Here is the deformity, and that was the fracture here. And angulation was like that. Then he came to my place. I have put multiple, corrected the deformity and fixed it with multiple K-wires. Because Fibrous dysplasia, you cannot get lot of bones, and that is not the way for getting treatment. And Ilizarov, from pathological these bones, it will convert it into normal bone. See, I have corrected the deformity. Now you can see here the massive callus formation. These are the console wires. You can put multiple console wires to increase the circulation, to increase the bone quality. Now this is, from external view, look at this. Look at this. This is the second ring, and this is the distal third ring, and this is before, and this you can see from that situation, quality of bone, quality of bone. Now this is the bone, and this is the lateral view. You can see a little bit deformity. This is accepted from this situation to that situation. This is only after 11 months follow-up. Now let us see another case, dear friend. This is the case. She is the young girl of our deputy director of director general of the health, and she went not only in my country, different doctors, even outside my country. Even they, I would like to say that went to the Bangalore, not Bangalore, in CMCH. They advised her to go for amputation. Look at this. Then came to me. Look at the left side. Look at the right side. Now she is my very good friend, master degree holder, already finished. She is my Facebook friend. See, look what I have done. You can see the super ankle, lengthening, gradual correction, and then lengthening, deformity correction, from back to right side, stop, plantar flexion. Now you can see lengthening of this one, fusion of the ankle, and this is, you can say, the super ankle of this one. And from that situation to this situation, look at this. It was the back side, like this, and now this is like this. Bone quality is good. She is happy, and now you can see how she is walking. This is before, this is after. It's good. Good. She's very happy. She's very lucky now that at least we could do something with this magical Ilizarov. This is the beauty of Ilizarov. In this case, although this is a simple non-union stiff, left tibia with lateral bowing, 5 years old girl. Look at this. You can go for opening, go for plating, go for nailing, whatever you like, but correcting the lengthening, and here, instability here, deformity, non-union. I have corrected, I can correct everything with this Ilizarov, magical Ilizarov. See, during treatment. Only I have done the osteotomy here, and with wires, gradual correction, and then with this, good callus formation. I have just little bit fibulotomy here done, and then after 4 years, from this situation to this situation, healed, but since the girl is growing, there is a problem with the growth plate here, and then she came to my place again. I have done the re-lengthening, and then again she came to my place. Father is working in Singapore. See, look, massive. And this situation, from that situation after 6 years, and this is after 10 years follow-up from this situation to this situation. This is the beauty of Ilizarov. See, now, see this case. Post-traumatic bump. This is, I call this monkey mouth. See the monkey mouth, 2 lips, deformity like this, hypertrophic. Yes, you can go for osteotomize, bone grafting, nailing, but very simple. only put the Ilizarov. This is hypertrophic. This is only the patient is not getting the mechanical stability. Here, osteogeny potential is too much. If you go distraction, putting on the first two rings, see, with telescopic, then I have changed the rings. See, after 8 months, and from bony bump from that side to this side, not the quality, only destruction of osteogenesis. After 6 years, it came to a place. This is also follow-up from this side to this one. And then after 6 years follow-up, you can see this deformity from the back, from the front, and this is from the front. And you can see this is also published in Medcraft American Journal, Judas quadriceps and treatment of Shepherd Krug, everything, bowing deformities. Now case this one. Controlateral bowing. Look at this difficult thing. Again, you should have to calculate yourself before going for any deformity correction. Then look at this with wires only. From this, after 8 months, from this situation to that situation. Oi, very difficult gastro 3B. He was treated elsewhere. And you see this discoloration of the skin. Skin is totally gone here, backside, and came to me with this. After 2 months, he came to my place, and this was the uniaxial fixator, treated elsewhere. Again, these are the challenging cases, and you can do a lot of things with the Ilizarov. And in the OT, see here, keeping this, I have put the wires, and then this gradually, at the same time, we're doing a little bit skin grafting also, sequential. And this is compression and distraction, lengthening. And this is 5 months follow-up. See the back side of the calcaneum. And this is sequential follow-up. And this is 9 months follow-up, you can see from the back side. And he has a very good video, and I have stopped that one because of internet. Sometimes if you run the video, you can face problem. So this is from their side to that side, this side. So this is another case. Vehicle collision, skin gone, see sole of the foot, dorsum of the foot, treated elsewhere. Then we applied Ilizarov, and gradually you see wire technique, the good healing process. This is the healing process. I don't know you have any idea regarding the wishbone technique. Wishbone. Sometimes we are doing that. We are wishbone technique. Transversely, we are distracting here. And as a result, we are getting a lot of new vessels. And that helps in healing process. So this is the clinical appearance of the patient. You can see the foot and at the same time sole and dorsum of the foot. This is the interesting case, dear friends. This patient came to me with knee dislocation, treated elsewhere. Knee dislocation. After three months, she came to my place with ulceration here. There was a vascular injury, clawing of the toes. And whenever I get this kind of cases, I know the Ilizarov help you wear technique. Ulcer of the foot, lateral border of the foot, you can see ulcer, clawing of the toes, and there was a foot drop due to the knee dislocation. And then what I have done, see there was ulcer also here. And by this time I'm telling you, I'm getting treating a lot of diabetic foot care. And they can be very nicely, you can treat by Ilizarov technique. And I've seen in my center, that is in Bari and BHS, lot of surgical friends, they're going for amputation and toe amputation or below knee amputation. Now, whenever I'm there, now I want to save all the limbs. You can see here. Now see the lateral border. After putting the Ilizarov, this is the wire technique. And what is happening? Now you can see here, this is totally healed lateral border. And this is clawing of the toes. And after that, I have done the TPT, tibialis posterior transfer. And the patient is okay now. So this is the bilateral relapsed CTEB. She was treated. You can see the difficulties of the toes, sole of the foot, cavus, and from the backside, she was treated elsewhere. Previously, at the age of when she was 2 or 3, and then came to me with this deformed bone and everything. Dear friends, I can tell you, I have not done any kind of osteotomy here. See, applied. After 1 month follow-up, you can go for gradual correction with putting the multiple wires in the toes up to the metatarsals, you can see, and differential destruction you can do, and you can see the sole of the foot. And she was running at that time 14 years or 15 years. Now see the situation back, and this is the front view. And at that time, when she was getting physiotherapy, I took the pictures. This is the full correction of the deformities. Stages of preoperative planning. Most of the Ilizarov surgeons, they know, but for young generations, those who are going for Ilizarov surgery, they must know all these things. You must know the true apex of the deformity. That is, we call CORA, center of rotation of angulation. And you should have to calculate the amount of deformity, how much you're going to correct, and how much you're going to lengthen. You should have to know the biomechanical designing. Determination of osteotable level is very important, and determination of osteotomy shape, selection of the deformity correction type. And this is the simple diagram. This is, I've taken it from Kurgan books. Hinge placement, look at the apex of the deformity. See here, this is the bisectal line. The Ilizarov surgeons know. Gradually, you can go for amount of wedge-shaped regenerated bone, how much you are getting here. Gradual destruction. And in Ilizarov surgery, everything must be done gradually. This is the formation of trapezoidal regenerated bone. You can see here. If you look at this calculation, C, A, this is the B, and you can see the wide base of trapezoidal regenerate here. And at the same time, you can see a narrow base of trapezoidal bone, regenerated bone. This is the bone width, and this is the connecting bar, bone distance you can see here, and A alpha, you're giving the deformity angle. And during the surgery, you should have to maintain the some stages. Osteostasis of leg bones, insertion of the wires, mounting of the Ilizarov fixator, and at the same time, placement of the hinge units for deformity correction. Sometimes you need to go for a skin incision, and you should have to go for the bone, and you should have to do the osteotomy, you should have to correct the deformity, and you should have to close the skin. And after doing that, you must check your bone with X-ray. And main principles of transosseous osteostasis of deformity correction: insertion of wires with the stoppers in the process of deformity correction, hypercorrection of the external supports of the transmission fixator during its mounting, proper efficient management or arrangement of the fixator hinge units. This is very important. This is also a beautiful thing that you should have to know how you can gradually correct the deformity. These are the very interesting cages. Very interesting. You can put the hinge like this, and one fixator here, one ring here, and this is your deformity. Go for osteotomy here, and gradually you just put the hinge at the level of the coda where you are going to osteotomy, and gradually you distract. You are getting a good regenerated bone here in the tibia and in the fibula, and your axis is okay. So this is also another variant of fixator configuration. How? See the placement of the hinges. This is very important, dear friends. So if you want to correct this one lengthen, do the osteotomy, unlock this, unlock this, unlock this, and go for distraction. And then you can correct your principles, periods of fixator stages that I am going on. This is stages. Postoperative stage management, gradual correction, residual deformity, proper dressing is very important, adequate functional and static weight bearing of the limb, efficient exercise therapy is very important, and controlling the regenerative bone condition. You should have to control, check every time, every 10 to 14 days. Periods of fixator removal are determined by the following: the mean periods of consolidation depending on the amount of deformity, limb shortening, patient age, and etiology. The presence of the exercise of newly formed bone in the data of clinical testing, the consolidation and stability. Principles of removing the transosseous rim fixator. When you are going for removing this, you should have to think this one. See, adherence to the indications for the fixator removal, consolidation, clinical signs, and those by X-rays. And in general, if you see in your X-ray the three cortices are already united and consolidated, then you can advise your patient go for dismounting the fixator. A patient should observe the following rules for removal of the Ilizarov fixator. Axial and functional loading of the limb should be gradually increased. Adequate exercise therapy should continue. And fundamental principle of Ilizarov methodology is load and motion. Load plus motion is equal to healing. Regular procedures of physical therapy is very important, and subsequent examination and control of the subsequent examination is very important. Now, dear friends, what are the tactical errors? Calculated errors. The wrong selection of the number and levels of the osteotomies. This is very important. The faults in the calculations of limb segment deformity and shortening. And at the same time, if you neglect the disease and what is the etiology of the disease, and if you neglect the age of the patient, you'll face the problem. So that's why regarding tactical and at the same time technical errors, these are the two important things you should keep it in mind. In the preoperative period, the wrong selection of the Ilizarov fixator supports and parts. While performing the surgeries, nor observing the rules of the wire insertion, biomechanical principles of mounting the fixator supports and units. And at the same time, when you are going for osteotomy, whether you are neglecting the soft tissues, those who are preserving your during the wire insertion and fixation. And the errors that we should keep in mind in post-operative period. We can see the errors. Unreasonable, frequently changing the fixator. This is not mandatory all the time. Non-observable of observance of deformity correction rates. The absence of timely access control of the dynamics of bone regeneration. Incorrect interpretation of the X-rays. Sometimes it happens. Premature removal of the fixator. This is also very important. And underestimation of the importance of exercise therapy and the possibilities of early limb weight bearing with the fixator applied. Of course, every surgery has got the complications. Complications are a fact of life for the orthopedic surgeons. Whenever you're doing surgery, of course, from minor to major complications you will face in your life. And these are the inflammation of the soft tissues. You will see before going for any Ilizarov surgery, you must tell your patient, this may happen, and these are the normal things. So postoperative neuropathy sometimes happens, consolidation in osteotomy site, cutting wires out of bones sometimes happens, wire loosening also. When wire loosening happens, you should have to change that one, or you should have to tighten the wire. Before, when you are going for any deformity correction or lengthening in the tibia, you can invite equinus deformity of the foot. To prevent that, You should have to know how to prevent the equinus deformity, and you should tell your patient to go for exercises all the time. And sometimes you are inviting knee contracture also, you are inviting pseudoarthritis formation, and you may get subluxation, you may get transformation to the regenerate bone, you'll get all these complications. So how can you can live life with Ilizarov frame? See, with the patients with different Ilizarov. If your construction of the Ilizarov frame is fine, if your wire are tightened, striving force around the rings are okay, the patient will feel very good, will not feel discomfort. Rather, patient will feel comfort. And if you don't meticulous follow up your frame every time, then wire are loosens, the patient may complain and tell you that, doctor, I'm facing a lot of problems and pains. So meticulous, intelligent follow-up is very important. Look at this, how the beautiful Russian girls doing, this is called the ironic exercise. See how they're doing in the rehabilitation center. And before going for any surgery in the femur, you must have this kind of cot and trolley so that patient feel comfort rather discomfort. And in my conclusion, dear friends, in cosmesis and deformity corrections, excellence is achieved by correcting the correct deformity at the correct coda based on correct planning by the correct method to achieve the correct correction. This is the things before going for any deformity correction. The man who made it possible, 15th of June, they invited me yesterday for attending the Ilizarov 100 years. Probably I may go, but I don't know still. Today is the 4th, 15th, 3 days, there is a grand reception there. And all the time I tell this carry home message. What I've shown you, my friend, these are the evidence, and this is the science, and of course the surgical skill of the patient. For Ilizarov surgery, this is the combination of mechanical stability and for biology, and this is the cost effective, and you can do that. And in my country, this Ilizarov is holding a very good foothold in Bangladesh. These are the books, and this is the Shepsov, my mentor, my teacher, my good friend. I've learned a lot of things from this gentleman and convey my gratitude. And thank you very much for your kind attention, dear friends.
Thank you very much, sir, for your nice and excellent presentation regarding the correction of deformity by Ilizarov. I would like to request Professor Harshad sir to share his valuable experience with us regarding the deformity correction by Ilizarov. Professor Harshad sir, please.
Yes. Thank you so much. Excellent, Dr. Bari. I have seen all his patients many times when I had been to Bangladesh, as well as seen all his work all over the world, across the world when we meet in various meetings and platforms. It's excellent. There is no doubt about it. And he's one of the best surgeons who uses the Ilizarov as his magic wand on all such patients. And he has showcased it across the world. He's accepted, and he has been also recognized by the Ilizarov Center in Russia, Kurgan, as a visiting professor because of that. Congratulations, Dr. Bari. Excellent.
Thank you, my friend.
And he has shown all his cases, whatever he has done. I too have my share of all such kind of cases after working for more than 25 years, 3 decades plus in Ilizarov surgery. Things are very easy once you understand and separate two things what Ilizarov had told. One is the fixator itself. You use the fixator to your advantage of all its usefulness. And second is the principles of Ilizarov. The basic principle of Ilizarov is neohistogenesis. You regenerate new tissue very gradually and slowly in the direction that you want. So if you have a deformity like this, you've seen Bari's deformities, which are so grotesque. He has understood where the deformities are and corrected every deformity. Suppose you have 2-level deformity like this. You have to just straighten it like that. It seems very easy to us, but for an onlooker, it looks very difficult. What is this? It's so difficult what to do. You understand? So the same deformity we correct in a different axis and angle for this, and a different axis and angle for this. And you cannot do it acutely in regular surgeries, because if a deformity is like that and you try to correct it acutely, the nerves and vessels will get stretched so much that you'll get paralysis and a useless limb, or you'll get gangrene because of loss of blood supply. Hence, you have to do it very gradually. And only the Ilizarov technique and Ilizarov external fixator allows, or for that matter, you can use other fixators also nowadays, allows you to stretch very slowly. I'm sorry. It allows you to stretch the deformities very slowly at the rate of 1 millimeter per day or 1 degree per day to get it corrected. That's why it takes sometimes months and sometimes years for such most difficult deformities. And most of them, what used to be amputated earlier, such gross deformities with infection without any bones, now we are able to regenerate the bones and tissues and grow them very well. And one big advantage, like he has told, is for diabetic and diabetic foot wounds, where you just have to put Ilizarov. Professor Shah was there. His technique of only drilling the bones, or the next step of putting the Ilizarov rings, or the next step of putting the rings and doing a transverse osteotomy to increase blood supply. That is known as angioneogenesis. So increasing blood supply to the foot. By increasing blood supply to the foot, you're increasing the chance of wounds to heal, and you prevent amputations. Also in rest pain and gangrenous development of thromboangiitis obliterans in smokers. So Ilizarov has got vast applications from birth to old age for all varieties. And Bari has probably covered everything in a very short period and excellently spoken. Well done, Dr. Bari. Thank you so much. I too have very good experience, and I have full respect for Bari for his work.
Thank you, sir. Thank you very much for sharing your knowledge with us. But now I would like to request Dr. Shamsul sir to share his experience regarding the correction of deformity.
Thank you, Dr. Tanvir. It's always been a great privilege to learn from my mentors, Bari sir, Harshad sir. They've been my teachers, and I've learned from them, a lot from them. So my message to the youngsters that you have to first understand the basics of Ilizarov, follow the basics of Ilizarov first, follow the biology, follow the principles of deformity correction one by one, and as Harshad sir said, go to correct all the deformities one by one, understand them very carefully. This seems very easy, but you have to go gradually, step by step, follow each and exact principle precisely. And following all of them, we have been done a lot of deformity corrections at Patna also. And it's really a great pleasure seeing a lot of surgeries from Bari sir. Thank you.
Thank you very much, Dr. Shamsul sir, for being with us. And it's a great pleasure for me also to have Professor Harshad sir and Professor Bari sir in a single screen. And it's a great day for OrthoTV also. And dear viewers, hope we will see you in the next Friday with another topic. That is the magical Ilizarov. Till then, I am Dr. Tanvir Ashraf. Want to thank Renata Pharmaceuticals for sponsoring us, and want to thank OrthoTV for being with us. And definitely for the viewers, I would like to request our viewers to be with us, and hope we will see you in the next Friday. Till then, have a nice day and have a safe day. Assalamu alaikum. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.